evening on your Wednesday evening. I'm so excited to be here and to welcome you to the North Carolina Down Syndrome Virtual Speaker Series. It is hosted by NCDSA in collaboration with the other Down syndrome support organizations across the state, including Coastal Buds, the Down Syndrome Network of Onslow and Carteret counties, the Down Syndrome Network of Greater Greensboro, the Down Syndrome Association of Greater Winston-Salem, the Down Syndrome Association of Greater Charlotte, and the High Country Buddy Walk. The North Carolina Down Syndrome Virtual Series is held the third Wednesday of every month at 7:30, and it is free. It will run through February. All of the session descriptions are on the registration page. And just so you know, the registration opens the first of the month before the month of the webinar. So you can now register for October, and come October 1st, you'll be able to register for November. Please know that registration closes on Monday night before the webinar so that I have time to prepare the information and get it out to everybody on Tuesday. Barring any issues with technology, tonight's session is being recorded, and you will be provided a link to the recording and Jenna's slides and a follow-up email next week. I would ask you to please take 1 minute to complete the questions in a brief survey. The link to that was included in the email that included the link to Zoom. Auto-generated captions have been disabled, and you should be able to turn those on your end if you would like those. The question answers, please use the Q&A box and not the chat feature. We will not be monitoring the chat feature this evening. Tonight's webinar is how to get on the Innovations Waiver waitlist. It's in front of you. Why it's important and what to do while you're waiting. It is presented by Jenna Flynn, and I'm reading it. Jenna Flynn of the Autism Society of North Carolina. I would like to welcome Jenna Flynn and thank her for sharing her expertise on this very important topic. Jenna, the floor is yours.
Thank you, Donna. So like Donna introduced me, my name is Jenna Flynn. I am a clinical social worker at the Autism Society of North Carolina. Also after my name, the NADD-DDS is a certification for dual diagnosis, which in this case is IDD in mental health and or substance use. At the Autism Society, I have a pretty broad role, which I enjoy. One of my primary roles right now is acting as the clinical supervisor for our tailored care management pilot. And so for those of you here today who may have heard a little bit about care management, it is a new service through Medicaid for people who have higher support needs and are on the tailored plan. I will talk about tailored care management and some other Medicaid transformation things at the very end of our time together today. In addition to supervising care management, I also provide specialized consultative services at the Autism Society under the Innovations Waiver. And I also have a small caseload of people where I do outpatient psychotherapy. So all the people I work with, because I'm at the Autism Society, they do have autism, but they have other things as well. And for some of the folks, we're doing some family therapy because that's definitely what is needed. But all of that aside, I'm here today to talk to you about something that I care a whole lot about. I'm really glad that you all are here, and I do hope that you can walk away with a little bit more information and a little bit more clarity about the Registry of Unmet Needs, also known as the RUN or the waitlist for the Innovations Waiver. So today, while we're sharing this evening together, we're going to answer the questions that you see on your screen. I think these are really important questions. It's a lot, so I am really glad it's being recorded and that you can have these slides to refer back to if you ever need. I also will be sharing my information. I am happy to answer questions while we're here today, and even help kind of figure out some more complex situations that might arise. But we want to answer, what is the RUN? Why is the RUN important? And remember, RUN stands for Registry of Unmet Needs. That's that wait list. How is the RUN managed? What does the LME-MCO require to get on the RUN? And underneath that, lots of questions. What is a psychological evaluation? What is a qualifying diagnosis? Why does the diagnosis need to be present before age 22? We're going to talk about that because that one's a little tricky. Diagnoses need to be clearly listed. You need to have something called adaptive function assessments. And then the last ones are pretty big. What should I do while I'm waiting? How long will I be waiting? The North Carolina Innovations Waiver is a huge program with lots of nuances all of its own. Today, I don't have time to focus so much on that, but rather on what comes before it, which is the wait list. So on your screen right now are several terms that are all used to refer to the wait list. So you might hear the Innovations wait list, the Registry of Unmet Needs. Someone might be referred to as on the run. They might call it IDD eligibility, and it may also be called the waiver wait list. These phrases are all used to refer to the same exact thing. So the first question, why is the run important? Well, it's important for a lot of reasons, but the biggest ones in my experience are that this is the main way or the main process to get an innovations waiver slot in the state of North Carolina. If someone isn't on this wait list, then they really don't have too much of a chance of accessing innovations. Being on this wait list also makes sure that the LME-MCO is aware of someone in their family, what their diagnoses are, what they need, like how high their support needs are. And lastly, all of this information is data that the LME-MCOs and state leadership can use when they're trying to figure out, what is the need out there? How much capacity do we have? How do we use any funding we have? And even deciding what types of new programs we might need in our state. I think these numbers are pretty impactful, so I do like to share them. The run is important because about 12,500 people currently receive innovations, but even more than that, 15,000 people are waiting on the run. And we also know, and this number is probably much larger than 10,000 at this point, but there are even more people who are eligible for the innovations waiver, but they're not even on the waiting list yet. For further evidence of that, in the care management program at the Autism Society, we have about 140 clients that were assigned to us. Only 30 of those clients are on the innovations waitlist. About 10 of those, so that leaves 110. 10 of those applied and were denied. So there's 100 left who have never applied. Whenever we talk to them about the innovations waiver and the wait list, most of them have no idea what it is. They don't know why it's important, and they have no idea what it could do for them. This is one huge reason why care management, in my opinion, is so important. Care managers can serve as a portal to services and programs that a lot of these clients really haven't ever heard of. So the run is managed in North Carolina by let's see, we've got 6, and I think some are consolidating. So we'll have 5 LME-MCOs. So that acronym stands for Local Management Entity / Managed Care Organization. So what it is, I think the easiest way to think about it is it's like an insurance company for Medicaid. So for example, Alliance Health in pink, they are the Medicaid insurance company for all of the counties in pink. They contract with providers, a network of providers that provide specific services that they cover under the Medicaid insurance plan. Above and beyond that, they are responsible for managing the funding that they get from the federal and the state government that is specifically for services and supports for people that have intellectual and developmental disabilities, mental health diagnoses, substance use needs. So in that way, they are unique. It's not just Medicaid. Even if a family has private insurance, if they have an intellectual and developmental disability, the LME-MCOs are someone that they should know about, especially for the Registry of Unmet Needs. We're going to talk a little bit about some myths, some misunderstandings, but just as a teaser, one of the misunderstandings is you don't have to have Medicaid to get on the Registry of Unmet Needs. You can be privately insured. The Medicaid comes later whenever you're offered a slot, but just to get on the wait list, you can have private insurance. You don't have to have Medicaid. Each LME-MCO in North Carolina is also responsible for managing that wait list or that Registry of Unmet Needs for the counties that they oversee. So again, thinking of Alliance, they manage the wait list in the counties that are pink. So in that way, I think all clients, families, they need to have the current contact information for these LME-MCOs. This is a super important piece of the process. And just to go through the list in case it's not super clear on your screen, these insurance companies for Medicaid are Alliance Health, East Point, Partners, Sandhills, Trillium, and Via. And just a reminder, if you have any questions pop up, just use that Q&A and Donna's going to help me field those. So we know that the LME-MCOs are responsible for overseeing that wait list, but how do they do it? I personally think it's pretty interesting and important to know how they manage it across the state. So the easiest way I thought to explain this is to think of the Innovations Waiver. It's what they call slot based. So if you think of slots on the waiver like chairs at a table, the goal is to fill all of the chairs at the table and then have a wait list for people who don't have a chair. So in that way, if someone leaves their chair and they stay out of their chair for a specific period of time, then the LME-MCOs, they're going to refill that chair or that slot with someone new from the wait list. So there are some reasons why someone might leave their chair or leave their slot. Sometimes they choose to give up the waiver, or if they pass away, they're no longer on the waiver. If they enter an institution for a certain amount of time, and in this way, an institution, it's usually something like a hospital or jail or an ICF facility. And also if they move out of state, then they have to vacate that slot. They can't keep the waiver slot if they live in another state. Additionally, each LME-MCO prioritizes the waitlist by time waiting, which means the people who have waited the longest are at the top of the list, and the people who have just been added are at the bottom. And this is regardless of your level of need. On your screen at the bottom, I made a little spreadsheet just as a visual example of what a wait list could look like. There are several people who registered on that same date. It goes down to the time, down to the minute sometimes. So if you call in at 4:30 to get on the wait list and someone else calls in at 4:49, you would be ahead of them in line. When families call the LME-MCO, we recommend you say something like, I want to be placed on the waiver wait list, or I'm calling to get my child on the run. That officially begins the process. So again, that spreadsheet on your screen, the date and the time of your call to the LME-MCO is logged. And after you submit any required documentation, that date and that time is where your name is going to be on that wait list. The other important thing to know about the wait list is that they're kept at the county level. So the wait lists and the time waiting are going to be different for each county. LME-MCOs, they're in charge of determining how to assign the slots that they receive across their whole catchment area. So it gets a little tricky to, and we'll touch on this later, but to say how long it's going to be whenever you're on the wait list, because people are moving into and out of counties. And so the wait list is kind of always changing in that way. There are a few misunderstandings or myths about the run that I do want to clear up before I jump into what documents you're going to need to get on the run or on that wait list. So like I mentioned, the first one is a biggie, and I definitely want people to take this away from today and to share this with other people. You do not need to have Medicaid to apply for and to be on the wait list. So again, you do not need to have Medicaid to be placed on the Innovations wait list. People do not need to be deemed disabled by Social Security in order to apply and to be on the wait list. Those are two very separate things. I think in that way, people can have somewhat high need or lower support needs. They can be more highly skilled in different areas, live independently. Some people that I've supported, they independently drive. They might work part-time. They can still qualify for the waiver wait list. It is not only for people who have more severe or profound support needs. I think the other biggie is that there's no lower or upper age limit for the waiver. So as soon as someone has a qualifying diagnosis, they can reach out to the LME-MCO and start that process. So as an example, and I think this could be pertinent for people here or people that you might talk to, I worked at an LME-MCO and we spoke with a pregnant mother whose child they did some of the, I guess, the scans while she was pregnant, and identified that her child, had a high likelihood of having Down syndrome. And so she called us whenever she learned that, which I thought it was pretty great that she even knew to do that. As soon as her child was born and they had that medical confirmation and they had some medical record, she reached back out to us and we were able to place her child on the wait list immediately. And that's really important. We'll touch on this later, but the average amount of time people spend waiting for an Innovations Waiver slot is last piece of data I saw was 9.5 years. And that's the average across the state. We know that some of our counties are quite small and some of our counties are bigger and have larger populations of people that have qualifying diagnoses. So it's going to fluctuate, but that average is still pretty long. It's about a decade. On the other side of things, we definitely have worked with adults who they've had these diagnoses and needs their whole life, but they just were never identified. They were never connected with these supports. And so they could be in their 40s, 50s, 60s, and just getting on the wait list. But again, if you're not on the wait list, your name is not ever able to come up for the support. And so we always recommend, regardless of age, just try to get your name on the wait list. And again, if there's any specific questions, concerns, confusions, definitely use the Q&A so that we can touch on those. So here's a big question. What specifically does my LME-MCO require to get on the run? What is the process? The truth is, it depends. There is variation among the LME-MCOs across the state. No two LME-MCOs do the exact same process. So that makes all of this more confusing for everyone. I won't go into all the reasons today why I think there's variation, but we are going to talk a little bit about things that are the same and what you can expect. So before we do that, sorry about that, there isn't a standard process across the state. When I was initially putting this presentation together, I called each LME-MCO and I just asked what their process was. And what I learned was that it's different from each LME-MCO to the other. Some LME-MCOs will require that you complete an assessment with them, which can take anywhere from 30 minutes, 2 hours. For anyone here that could already be on the Innovations Waiver, some LME-MCOs had folks sit for the SIS assessment, which can be several hours long. Some LME-MCOs just have a questionnaire that's done by phone. Some ask for your consent whenever you talk to them because they're going to staff your case in a bigger clinical group called an eligibility committee. And then the committee together makes a decision based on the information provided. And so that information isn't always what your doctors or specialists say, but it could be what you're sharing, which I think is tricky because they don't tell you exactly what to share, right? And some LME-MCOs have really strict requirements for the scores that are from the evaluations. So for example, they want your adaptive function scores to be at or below 70 to be found eligible. And just to get in front of any questions here, I can confirm the state is aware of the variation among the LME-MCOs. But as of today, as far as I know, there isn't a solution yet to kind of fix that. So despite the actual process at each LME-MCO having variation, I did find, and in my experience, there are some really basic pieces of information that you're going to need regardless of which county you live in. So we know that you need to have a psychological evaluation and or medical documents that contain all of the items on this list. So, and we're going to go one by one through these because I want to make sure that everyone understands what each of these things is. So first, a qualifying IDD diagnosis that is clearly listed and began before age 22. So I'm going to explain why that age is important in just a moment. A psychological or medical assessment that confirms the diagnosis using tools and documenting which tools are used. And then an adaptive function assessment. So we're going to go one by one through what all of this means in a little bit easier to understand language. So first, what is a psychological evaluation? I'd say very frequently, intellectual developmental disabilities are diagnosed through a psychological, which is a process as well as a document. The process and the document, it gathers developmental, medical, behavioral, psychiatric history. It also uses tests like IQ tests and achievement tests. You may have had to take questionnaires or assessment tools. And then the psychologist who completes it, they're going to also add in their observations and interactions that they had with the individual. All of this is put together to assess someone's symptoms, their behavior, and ultimately what they need. That whole process, and also in the document, it results in a diagnosis that is clearly listed in the document. And It should also provide recommendations for what to do to gain more information, to find help, and to build skills. Sometimes this piece can be confusing. So a qualifying IDD diagnosis, it can be one of any number of diagnoses. We often talk about IDD as an umbrella, and you have all of these things underneath it that qualify. They are an intellectual and developmental disability, but IDD itself, it's a broad term. It's not a diagnosis. And why does the diagnosis need to be present prior to age 22? The answer is that the Innovations Waiver by design serves individuals with an IDD. So by definition, IDDs begin during developmental years, which is up to age 22. I think where this does get sticky is that some people don't have documentation from their childhood that confirm a diagnosis. Maybe they had documents, but they were lost or destroyed. And some people, they share that they never got any formal help until they were already over age 22. And all of this is okay. It's actually becoming more common in my experience. And I think in that way, more and more professionals, they're becoming skilled at helping these individuals, at gathering that important information to confirm that this was present before they were 22 years old. The way that they do that is they often talk to what they call early reporters. So someone who knew that person well whenever they were under age 22. And then I think the other piece is that just needs to be really clearly in the document, is that we didn't have any documentation, but I interviewed these people. It's my clinical opinion that this was present before age 22. And the last piece of that first section is that the diagnosis needs to be clearly listed. So what does that mean? At the top of your screen is an example of a diagnosis being clearly listed and confirmed. So it actually says diagnosis, it has the code, it has the actual diagnosis written out. All of these diagnoses, the evaluation's up here and it says, here is the result. At the bottom of your screen is an example of language from an evaluation that was done in a public school. They're also called psychoeducational evaluations. This evaluation typically does not work to get someone on the Innovations Waiver, simply because it does not clearly state the diagnosis. So that highlighted language, it says falls in the severe symptoms of an ASD. So it talks about what their score was and kind of that they're in that severe range, but it doesn't say they actually have this diagnosis. And I think that's a little confusing because the information is there, but that diagnosis is not clearly listed. We talk a lot as an organization to individuals and to families, just trying to help them get updated testing that has all of these correct components. For people that have, an evaluation that looks like the one on the bottom that just doesn't have a diagnosis, sometimes it can be an easier and a quicker updated evaluation because all of it's there. We just need a professional to kind of interpret it and actually give a diagnosis. So next we want to talk about the actual assessments or tools that are used to confirm a diagnosis. Generally, the type of evaluation needed to confirm a diagnosis should match the general type of IDD it is. So this piece is also confusing. It can create some frustrations for families. So I'm hoping that this can really help clear some of that. Generally, if there is a medical or genetic cause to the IDD, the LME-MCOs will want medical or genetic documentation to confirm that. If the IDD is related to delays or disabilities in motor function, the LME-MCO is going to want documents from specialists in motor function, like physical therapists, or for very young children, occupational therapists. The aim here is to make sure that the person that provides that diagnosis, that puts it on a medical document, is actually a specialist for that area and has the authority to diagnose it. So on your screen, I put some examples, and these are merely examples of the type of diagnosis and then what kind of documentation, in my experience, the LME-MCO would want to see. So for autism, there are really specific autism assessments that they want to see that a specialist used these tools and came to the conclusion it's autism. For an intellectual disability, they want to see that a qualified psychologist used IQ testing and was able to come to the conclusion that it's an intellectual disability. Again, in this area, if there are any questions, just use the Q&A. We can do what we can to help further clarify it, because I know that this part can also be confusing. The last necessary piece of documentation is the adaptive function assessment. So LME-MCOs require adaptive function assessments within the psychological evaluation. It's typically one of the tools or measures that is completed in a full psychological evaluation. On your screen at the bottom are 4 examples of tools or questionnaires that are often completed to help determine someone's adaptive abilities. Those are the Vineland, the ABAS, the DABS, and the SIBR. So what is adaptive function? How do we assess it? Adaptive function, it's just really looking at, we have the diagnosis, but we want to look at, or we want to measure with numbers how easy or difficult it is for a person to do a variety of activities just based on having that diagnosis present. So in that way, it helps determine how that diagnosis impacts them across a variety of life areas. Adaptive function is measured in 2 ways. So first, and I think this is a really common one that I've seen for psychological evaluations, individuals and families, they can self-report how easy or how difficult it is for them to do daily function activities to a professional. Sometimes that's the first thing that pops up. And then, the professional might say, okay, let's assess this a little bit more. Let's get you connected to some things, which can lead to the more formal second piece where someone who knows that person well, they're actually going to complete psychological questionnaires. So going back on the screen, these 4 at the bottom, these are checklists or questionnaires that you read a statement and you kind of use your judgment based on what you know about the person, how easy or how difficult it is for them to do specific things. So I wanted to provide some examples of areas that are measured for adaptive functions. So these are actually some of the question areas that you might see in these questionnaires. An individual can say the month and day of their birthday when they're asked. Can they help prepare foods that require mixing and cooking? Can they travel independently to an unfamiliar place? Can they fill out a job application? Once these questionnaires and the self-reporting is all compiled, they show up as summaries within the document about what is reported. And then they also show up as a grid with some numbers, some actual number scores. Some LME-MCOs are very interested in these scores. I've seen plenty of evaluations that don't have the scores, and then we have to go back to the psychologist and say, we really need those scores. Because again, some LME-MCOs are very interested in the scores. So I'm on the wait list. let's say you go through all the process, they look at your documentation, you've got the right stuff in there, and they say, okay, we find that you're eligible. We're putting the day you called, at the time you called, and your name on our wait list. Now, what should I do? So while you're waiting, the big thing I think you should do is ask, what is available for me while I wait? The answer is a little complicated right now. So for right now, and what has been the case for quite a few years, is that there are Medicaid funded services that are available while you wait. And then there are some services that are funded through state funding or other flexible kind of pots of funding. So for folks who have had Medicaid, who have been placed on the Innovations Waiver waitlist, they could get supports like community living and support, which this is another area where there is variation across the state between MCOs, LME-MCOs. Not every LME-MCO has offered community living and support. I think most of them, perhaps all of them, have offered respite. There's a service called Community Guide, and there's a service called Supported Employment. For those people put on the Innovations Waiver waitlist, the LME-MCO might say, okay, you're eligible for these services, and would perhaps help send a referral to providers. We also know that staffing for these services has been really complex. So I do hope that either you all who are here participating or the agencies that you're connected to are kind of keeping up with the budget negotiations and all of that with the legislature, because there are some pieces in there to increase the reimbursement rates and the pay for staff, and very, very hopeful about all of those things. And then on the right-hand side of the screen, there were some services that are state funded, or there's some other funding. A lot of variability in terms of where you live, which LME-MCO manages your area, as to whether some of these things have been available to you. What I always recommend, because of that variability and changes that can happen, sometimes quickly, I would recommend that you call the LME-MCO just to find out exactly what's available to you in your county at this time. And don't be afraid to call multiple times a year just to check in and see what else could be available. The complicating piece is that there is Medicaid transformation happening right now. So there's quite a few things that are in flux and that are changing. The Registry of Unmet Needs, that Innovations Waiver waitlist, is going to remain a thing, right? It is not going away. The LME-MCOs are going to continue to manage it. So that is a piece of the puzzle. You do need to go through that process. But what is changing, and it's in process, it's not actually launched yet, is that there will no longer be the B3 Medicaid services versus the state services. There are now going to be, there's a 1915I waiver that will include the services that are listed on your screen. They are not yet available. The clinical coverage policies are being, I think, read and edited and posted for comments, and so they're not available yet. The other big thing I want to make sure everybody knows is that these services are only available with Medicaid. I can't say for sure then what happens to folks who don't have Medicaid but may have qualified for some of the state-funded services. I think those are important questions to be asking the LME-MCO that manages the county that you live in. The other thing that's really different about 1915I services is that folks have to be on what's called the tailored plan. So having Medicaid and being seen as having higher support needs, longer term support needs. And the assessment, kind of the threshold to qualify, is it's considered an entitlement, and the assessment that is completed to get someone into 1915I, you don't have quite the threshold that you do for the Registry of Unmet Needs. So it's my anticipation that more people will be able to access 1915I than ever could B3. I'm happy to talk more about that if that's confusing. These are really big, kind of nuanced topic areas, and they all kind of overlay. So I apologize. I'm doing my best to definitely give kind of the way that they interact without, being too confusing. The other things that I recommend that you all do while you're waiting, absolutely call at least once a year to verify your date, time, and your contact information, address. Make sure that you're still on that wait list. Most of the time, absolutely, there will be no hiccups. You're on the wait list, but we have definitely worked with some people who they were on the wait list and suddenly their name couldn't be found. For that reason, I also recommend that you keep any paperwork, any documents that are sent that have confirmation that you're on the wait list, the date that you're registered, because we have been able to get people added back on because they had that important paperwork. I always recommend that you keep the LME-MCO up to date on what your needs are. So if your needs increase, if you're going through a particularly hard time, I know for some folks as they develop, right? Like maybe when they're younger, their needs were lower, going into puberty and the social stuff at school and in the community, the stakes get higher, and sometimes you go through these tough spots. And I always recommend that the LME-MCO be on the list of people that you're calling. I can't guarantee that they're going to have a solution for you. I can't guarantee that they're going to have really much of anything to offer you. But what I do know is if they know about what you need, they're documenting it because they have to, right? You call them, they're logging what you're telling them. And if there comes a time where you need a higher level of support, they have a body of evidence right there in your chart that really speaks to that. You have been reaching out and letting them know and asking for help. There are so many ways that is so important to have all of that documented in one place where the people are making these decisions. And so I just encourage you to definitely just make sure they know that you're having a hard time and that you're doing everything that you can, or that your child's turning 18 and you're pursuing guardianship, and make sure that's on file with them. The other big reason is that they do get emergency Innovations Waiver slots once a fiscal year. And you can always request that your name or your family member's name be placed on that list for consideration. They're going to look at service history and any information they gathered from you if you called them. And so definitely just really consider calling them and just letting them know how things are for you and your family. The impossible to answer question is, how long will I be on the wait list? When will I get a slot? So there's several reasons why this is impossible to estimate. As I touched on earlier, each county is going to have a different amount of movement in their wait lists as people move into the county and out of the county, as people leave their slots for whatever reason. Some people on the wait list, maybe their name has come to the top, but the LME-MCO can't get a hold of them, right? So then they're moving on to the next people. So someone could be number 50 on the list and end up getting a slot quite quickly because all of these people ahead of them never called to update their contact information. Sometimes people, once those 9.5 years or more pass and their name gets to the top of the list, they are found not eligible for innovations. They've developed and they've grown, and perhaps where they are now in their skill building, they are at a place where their needs aren't high enough to meet that level of care. And the last one, when an LME-MCO gets slots from the state, let's say maybe 60 slots, and they're dividing it between 6 counties, they're not necessarily giving 10 slots to each county. They're looking across the counties to look at, what if one county has 50% more people on the waiver than this other county? So they're looking to right size it and try to make distribution feel equal among the counties. I don't know that there's an exact science to doing that, but I know that that's kind of part of the puzzle. And so I just wanted to share, I could have 30 minutes just of resources. And so I do encourage, we can stay connected and share resources after. The 2 big ones I wanted you all to walk away with today. Tailored care management is a new Medicaid service for people who have Medicaid and who are not on the standard plan, people who are on what is going to be the tailored plan. Some people might not know. My child has Medicaid. I have no idea. So what I would encourage you to do if you fall into that or you're in that boat is to call the LME-MCO that manages your county and ask them, is my child enrolled on the standard plan or the tailored plan? In general, because the services and supports, the long-term services and supports for people that have intellectual and developmental disabilities, because they're only available on the tailored plan, I tend to recommend that families do what they can to be on the tailored plan. There is a process. I think it's a 1-page form that a doctor or a specialist could help you fill out to request a transition. To be on the Innovations Waiver, you must be on the tailored plan. To get 1915I services, you must be on the tailored plan. If you all are in the room, you're like, well, I know I'm not on a standard plan. I do have Medicaid. I have no idea who my care management agency is. You can also find that out by calling your LME-MCO. Care management is, it's, I think, like what case management used to be, like before managed care. It's really targeting whole person care. So it's not just coordinating formal services. It's kind of combining in what Community Guide was doing. So finding resources in the community, natural supports, but now it's also linking in medical care, pharmacy, social determinants of health. So you, as a family, are assigned a care manager who is really supposed to look at almost every piece of your life if you're willing and able to let them help you, just to take that bigger look to see opportunities to enhance quality of life for everyone in your family. And then just to touch on 1915I services once more, they are in the pipeline. I am honestly quite excited for them, hopeful, I guess cautiously optimistic, maybe I'll say. It is not just for people with intellectual and developmental disabilities, but it's actually being expanded to folks who also have things like serious mental illness and substance use and TBI. So there is more information at the link along the bottom. And there are advocacy organizations across the state that are staying very on top of this process. And so I feel pretty confident when they are actually ready to go, there will be a lot of media attention, and we will all be notified, and hopefully more people will be getting the support that they need. So, all right. And I think we're pretty good on time. So I see that there are some questions. I'm going to go ahead and take my presentation away. And that way I can see the Q&A.
Jenna, that was fabulous. Thank you so much.
Yeah.
There's some complicated questions in here, and then there's some that are very easily answered. Lauren wants to know, does an IEP count as a psychological evaluation?
It does not. So the IEP is very much just a school document. It's the individual education plan. Sometimes it has the scores in it. It references some testing, but it is not the same. So your IEP alone is not going to get you on the Innovations Waiver waitlist.
Okay, thank you. And then trying to put these together here, Lauren and Meredith asked similar questions. First one is, what documentation should we get for Down syndrome? And then for a genetic documentation for Down syndrome, would the specialist that would provide documentation be a geneticist?
Yeah, so I think the important piece here is that whomever is providing that diagnosis needs to have been able to verify that the Down syndrome is present based on, if they did genetic testing, if it was based on just the physical presentation, there has to be evidence there that needs to be referenced in the document. I think ideally, if there was genetic testing done that led to the diagnosis, that would be what I would recommend that you provide. The other piece with Down syndrome is that there are also co-occurring IDDs along with Down syndrome. Like there might be intellectual differences, autism. So whenever there's more than one, you don't have to prove all of them. You don't have to have documentation for everything. So I think whatever you've got documentation for, that is what you should provide.
And for the Down syndrome, a karyotype from your child's hospital is usually a very good piece of information to be able to provide.
Thank you.
Joe would like to know, if you are already on the run, is it safe to assume the diagnosis is clear and properly documented already?
Yes, so you proved it at that time. I will say that, as things progress, the LME-MCO might come back to you to say, we want an update, right? Especially if you're ever at the top of the list and they're saying, okay, you're at the top of the list, there's a slot open. At that point, they're going to want an update. So what you used back when you got on the run is not going to cut it whenever it's time for a slot. But if you're already on it, you're good. Just know it's not good forever. You've got to get an update eventually.
So Kelly would ask, wondering if the assessments are still okay if several years old.
This is another place where there's a good bit of variation. So best practice, children should get an updated evaluation every 3 years. Adults should get an updated evaluation every 5 years. All that said, I don't know if anyone here has tried to get on a wait list recently, but they feel like they are years long in and of themselves. So the rule of thumb that I use is if what's in that document, in that psych eval, if it still matches your child or that individual, if it's still reflective, I think you're going to be okay. You are always going to run into certain providers that they're going to say, I think we need an update. And I can't always anticipate that, right? But I think if it's, I don't know, 5 years old, it's probably okay. If it's 12 years old, it's in your best interest to get on a wait list and try to get an update.
Okay. Danielle says, the letter we have stating that our son is on the wait list mentions submitting assessments giving at age 3. Is that important to staying on the wait list? So I know Danielle's child is past the age 3.
So there are different diagnoses, especially for our little kids. And I'll also lump in Liz's question about the functional assessments. So for a child under age 3, you might have just developmental delay, global developmental delay, right? That is not a diagnosis beyond certain ages that's still valid. So sometimes the other issue with age 3 is that services right now before age 3 go through child development services associations not through the LME-MCO. So they can put kids on the wait list before age 3, but it's hard to test their adaptive function before age 3, right? Because they're so little. And exactly what Liz is saying, right? For a 4-year-old, some of those questions aren't really applicable. So what ends up happening is that they recommend being retested at age 3, which it tends to be, if you're connected with the public school system, they'll do testing at age 3. That's whenever they have, I think it's called the DAYC, but it's kind of a more global assessment for young kids that's going to test their cognitive functioning, their gross and fine motor, their speech and language. So it is catered to young kids, but they're able to get some of that adaptive function stuff out of that same assessment for those really young kiddos. So you're right, those examples don't apply to really young kids. It's more of a developmental assessment that they'll do for the young children.
And that kind of coincides when your child is in elementary school, they'll have a developmental delay description on their IEP, but once they turn 8, they're no longer to have that, and they must be reassessed and given a different evaluation from the IEP.
That's right.
So Meg says, is there anything we need to do if our child is already on the run? My daughter has been on it for about 6 years. Do I need to be concerned that she may fall off it? Just curious.
Yeah, no, that's a super good question. So there's no reason why someone should come off of the wait list. You're not receiving anything, you're just sitting on a wait list. But what I just wanted to be clear about is that mistakes happen, right? In my experience, the wait lists, and this was, 5+ years ago, but they were Excel spreadsheets. And so that's why I recommend keep your paperwork, call and make sure that your child's name is still on there. Your child's name should not be purposefully removed, but sometimes accidents happen. The other time where I think it gets sticky is whenever LME-MCOs are combining. So when Cardinal combined into via an alliance, so they took some of their counties, they had to move those people from the waitlist over and kind of consolidate with folks who are already there. And I think that that's just an opportunity for mistakes to happen. And so always, always, always just call and confirm. They're super used to people calling and getting those dates, but just call and confirm.
And so that's what Meg was also asking, is her daughter was originally on the run from Cardinal Innovations, which no longer exists. And you have been absorbed into Orange County. So Alliance Behavioral Health is your LME-MCO. You're in their catchment area. And what I like to suggest to people is, every year around your child's birthday, call, make sure you're on that list. And again, ask them what services might be available. As Jenna mentioned, services are not the same across the state. And in some instances, counties will provide funding for different types of services. And so, the next year you call, you ask that question, some funding may have come up for something that might be applicable for your child. So it's always good to stay in touch with your LME-MCO. And like I said, even if it's just once a year, calling, making sure they have your child, all your updated information, and asking if there's anything new that your child might qualify for. So let's see. Okay, we do want to put some good news out there that Candace knows each county is different, but her 3.5-year-old daughter, where they live in Guilford County, she put her on the wait list a bit ago, and she just wanted to say it wasn't a hard process, thankfully, and Sandhills was easy to get in contact with.
Good.
So it is nice to hear some positive feedback about dealing with the LME-MCOs. So do you have an estimate on how many individuals are on the wait list who end up not qualifying for a slot once they get it?
So I don't personally have an estimate. I will just share it's very few people. That is not the norm. What they measure is the level of care that is written into the NC Innovations Waiver as kind of the threshold for who qualifies and who doesn't. It's called ICF level of care. And I think that you have to have they call 3 functional limitations. So 3 areas of your adaptive function have to be significantly enough impaired. I was a care coordinator for Innovations, and I supported people that, were transitioning into their own apartment and they were driving. They still had those functional limitations across three areas, but they were still pretty highly skilled and they qualified. So I think that it's not the norm for people to not qualify once their name comes to the top of the list.
Mhm. So I do want to make sure I understand this correctly. There's no limitation as to when a person with the disability can get put on the run, but did I understand correctly that they typically have to wait until they're at least 3 years old and out of early intervention services to qualify for Innovations Waiver services should their slot come available?
So that I don't think that they have to be three to qualify for the slot. The way that it works right now is those B3 services aren't available for kids under the age of 3. Ages, up to their third birthday and under, they get their services through the Child Developmental Services Association. So that's where it gets a little, and that's going to go away once we go to 1915I, right? I think that they can still get
Okay.
those services, but they could also get 1915I. But that's where the age 3 comes in. So I think it's probably, I mean, I've never worked with someone who was 3 or under who had innovations. They typically go
Okay.
Cap C waiver, but I don't think there's any exclusion.
Okay, because I know, as we advise families to get their child on the wait list as soon as
Yeah.
possible, I work with Meet the Need NC as well, and some families were getting pushback. They were saying my child was too young, and that was where we clarified what the application to the Centers for Medicaid and Medicare Services
Yes.
stated, and that there is no
There
limitation
is
or
no limit.
restriction on the age to apply.
That's right.
Um, Marilyn would like to know if you could explain a little bit about what is developmental therapy or development therapy.
Yeah, so developmental therapy that was on the list of services, it's a skill building service. So right now, if developmental therapy is an offered service through your LME-MCO, it is kind of the equivalent in Innovations that was in-home skill building. And now they look at community living and supports, it's really developmental therapy plus personal assistance. Those are kind of a seamless back and forth because you're teaching a skill, reinforcing a skill, monitoring that they're doing it appropriately. But it's all around building skills, maintaining skills, learning new skills, and just preventing any regression in skills.
Thank you. Okay. And someone had asked what services are provided from the Innovations Waiver, and I provided the link
Perfect.
to the North Carolina Department of Health and Human Services. They're not very good about sharing information, but the link I shared does actually have a list of services that are
Yes.
provided. It's in plain language. It has links to other pages where you could find information, but that's actually I think the best way to figure that out. And like I said, I'm quite surprised that the Department of Health and Human Services has that as accessible and understandable. Um, let's see. Once on the Innovations Waiver, are you more likely to get services versus never receiving services via B3 due to a multitude of excuses for various providers for 2+ years, mostly staffing
Yeah.
issues?
So I feel for you, and I would love to say yes. I think the reimbursement to provider agencies is a little higher for innovations, but the past couple of years has shown that even folks with Innovations Waiver, which is the highest level of community support you can get, still don't have staff. And I think that I don't know. I'm hopeful that when the new budget passes, if I think they're voting on it tomorrow and Friday, there are provisions in there to not only pay staff more, but to reimburse at a higher rate to agencies. So hopefully they can recruit staff at a higher rate of pay. Um, I think it's tough because whenever, gas stations and department stores are kind of offering the same or a higher salary, it's really hard for these agencies to recruit people. Um, but yeah, I feel for you. I hate that. I can't say with certainty that it is going to be better until the money is there to back it up.
Yeah, it's a staffing issue across the state. It's a
Yeah,
staffing issue
national.
across the country.
Yeah.
So until our legislators put a higher price, higher priority on our loved ones with disabilities, that's not going to change.
Yeah.
Um, Marilyn asked, what if the most recent psychologist who does updated assessment isn't qualified to give an autism diagnosis, didn't do testing you spoke about, ADOS, etc.?
Yes. So the ADOS is one of the gold standard autism assessments. And, psychologists do need to be specially trained to administer that. So yeah, they wouldn't be able to confirm a diagnosis of autism without that. So what I would say is that um, you are welcome to connect with me. We can help you get connected to psychologists that can do that testing to really rule in or rule out if autism is part of that profile.
Okay. And Meg would like to share a note about Cap C. If you do have another Medicaid waiver like Cap C, you have to choose between that and the Innovations Waiver when your slot comes up. You cannot be on multiple Medicaid waiver programs. Thank
That's
you, Meg.
right. Yes. So you can be on Cap C and have your name on the Innovations waitlist, right? You can have that. But you're right. If you're on Cap C and they say, okay, your name's at the top for innovations, you do have to choose. And so it is a really weighing of what are the needs versus what does each waiver provide. And then the thing with innovations is it's lifelong, whereas Cap C, there is an age out. Like there's an age at which they're no longer going to be qualified.
And just so everybody knows, there are multiple waivers. There's also an adult waiver, I
Hmm.
believe, where people have to kind of compare what they would get for the adult waiver, which is more accessible, versus the innovations waiver, which will take longer.
Yes.
And so our first question I saved for last, because Kim would like to know, will Medicaid expansion affect the run?
So what I'm told is that in terms of the management of it, no. Um, Hopefully it will positively affect it by giving us more slots. Um, and I think the other impact is that Medicaid expansion will have more Medicaid eligible people who will then also be pooling 1959 services and maybe getting on the wait list, which could make the wait longer. But all of this again is data. I think it's telling our legislatures that the little 100 waiver slots you give us every so often is just not going to cut it. So,
And the theory behind the Medicaid expansion is more people, there will be more money in the Medicaid pool. And so that could in some way impact services for people with disabilities. It might not necessarily directly impact the Registry of Unmet Needs, because that is a specific funding stream that our legislators, our North Carolina General Assembly, our state senators, and our state House of Representatives, they need to decide how many slots we're going to fund. I do have an update for how many people are on the Registry of Unmet Needs. This has come from the government liaison for the Department of Health and Human Services to the General Assembly. And as of May, there were over 17,000 people on the Registry of Unmet Needs. That said, this budget that we are still working on, that is, I think, 80 or 90 days late. It starts July 1.
yeah.
And it's a 2-year budget, so they're allocating money for the next 2 years. Our state legislators came up with 350 waiver slots
Across the state.
across the state.
Yeah.
So I am the advocacy and outreach director for the North Carolina Down Syndrome Alliance, and I can't stress to you enough how important it is for you to get in contact with your local state and representative and senator and your congressional, your Congress, your members of Congress and your state senators, and have personal relationships with them, especially on the state level. It is so easy to contact your state representative and your state senator. It's easy to have a conversation with their legislative assistant. They all have a legislative assistant, except for people higher up in their party that have more roles. They don't have staff. they have a legislative assistant. Some people have an office the size of a closet. So the people at the North Carolina General Assembly that are making the rules, they don't know anything seriously about a person with a disability. There's a few people, few legislators who have a child, maybe with autism, maybe with Down syndrome, but there's not enough that have personal lived experience and know what our daily lives are. They need to know we exist.
Yeah.
You know, if all 17,000 people showed up in Raleigh one day, they'd need to pay attention. But they're talking about Medicaid expansion. You know, we have a very strong healthcare hospital lobby in North Carolina. The gambling lobby, it's big. That's what they're paying attention to. That's what they're making budgets and laws about. They're not talking about our kids needing the Registry of Unmet Needs, having slots filled. So I can't stress enough. If you want information on how to contact them, who to contact, what you need to say or do, I am happy to share that information. You all have my email address because you all got the link. And one of the things I want to stress is that as a person with a disability or as a family member or primary caregiver, you're the expert when it comes to that person. Okay. My son has, you know, Down syndrome. He has a heart defect. Okay. The geneticist, his cardiologist, you know, I defer to their better judgment. But when it comes to making a decision together, I'm the expert when it comes to Thomas. And you have to remember that that has great value and great worth when you are talking to other people. I want you to wear that as like a badge of honor. You know, you carry a lot of weight with you. That is so important for you to remember that. And the other thing too, bring your child with you. I don't care if your child is rolling around your senator's office floor. That is your reality.
Yeah.
And they need to see that and they need to know that. And you can't really express that in an email.
Right.
And don't apologize for that. Do not apologize for that. So I will get off that soapbox because Kelly would like to know if y'all know when the tailored plan is scheduled to start.
Oh,
Nope.
Kelly, no, we keep getting
Nope.
emails. It's like October, just kidding. To be
Yeah.
determined. And Donna and I were talking before she opened up the webinar about how it's like standard plan has launched and everybody else is just kind of like, it's like hurry up and wait. And we're just kind of in this like lull because 1915I is not available. So
Yeah.
it's no man's
what do we
land.
do? Yeah.
But yeah, there's not a lot to do.
No. And at least this time, the Department of Health and Human Services didn't throw out a date to postpone.
Yes.
So, you know, at first it was postponed to December 1st, 2022. Then it was postponed to April 1st, 2023. And then it was October 1st, 2023. And this time they just said, hey, you know what? We're not ready.
Yeah. No.
So I hate to make light of it, but that's basically it. And there's not much. Well, actually, there is something you can do about it. One of the problems is, so Medicaid is health insurance. And so for the people outside of our community who don't have excessive needs, they are just getting health insurance and they're on what's now called the standard plan. And the state contracted with insurance companies that already exist, okay, to administer the standard plan. And that is why if you're on the standard plan, you get to choose, I guess, out of 6 or 8 insurance companies, such as Blue Cross, AmeriHealth. I don't know all the names. And so they're insurance companies and they already contract with healthcare providers and accept Medicaid. All right. Well, the tailored plan, instead of contracting with insurance providers, they've turned our LME-MCOs into insurance companies. Now, of course, they have no way of administering insurance to people. So what the LME-MCOs had to do actually is go around the back door, and they're contracting with the insurance companies to help them sort this out. But because they're the LME-MCOs, they do not have relationships with your healthcare providers. So your healthcare providers have not signed up for the tailored plan. So what you could do to help is and you can email me to get the information if I don't remember to put that in my follow-up email next week that I'm going to write about PCP providers. You need to encourage your loved ones, primary care providers, therapists, anyone that you go through their insurance with, to sign up for the tailored plan. Okay, that is the major holdup that we've been told. That is what is delaying it, because what's happening is when they launch the tailored plan, your doctor is not on the list for your child to get their insurance from. So we need to get all those healthcare providers on the tailored plan. And you can send them a letter, you can call their office. There's simple information that you could share with them to ask them to please do that.
Yeah. And to clarify that too, it's not just like they're paneled with Medicaid. Like my doctor takes Medicaid, great, but do they take Alliance Medicaid? Do they take Via Medicaid? Do they take Trillium Medicaid? They have to go to each of those LME-MCOs and panel with them, which I think is such a bear for all of these medical and specialist providers out there.
Right. And especially you figure they already had to do that to be on the standard plan.
Right.
And I don't know how many there are, but there's at least 6 standard plan health insurance providers. So now we currently have 6 LME-MCOs. We're going down to 5, but that's still 5 or 6 other organizations that they need to contract with.
That's right. And the contracting is just as different between LME-MCOs as the Registry of Unmet Needs is.
So it's kind of insane. It's supposed to fix everything in theory, but we'll wait and see about that. One of the things you mentioned earlier was an ICF. So when you're talking about people going institutionalized care and losing their waiver slot, can you explain a little bit more about what an ICF is, and do typical group homes fall under an ICF category?
Yes. So a typical group home does not fall under an ICF category. ICF stands for Intermediate Care Facility, and it on the outside can look like a typical group home. How it's different is that the rate that these facilities are billed, they're supposed to put all of someone's needs and services under that one rate. The Innovations Waiver is an alternative to ICF level of care. So that's why if you go into an ICF facility, which can be a community ICF, it looks like any other group home. It could be a state developmental center. Those are considered ICF facilities. It can also be like a big community ICF. I know RHA has some really big, like many, many beds. If someone in your family or that you're working with goes into an ICF facility, they're kind of at that decision point. They need to choose one or the other. They can't stay on the waiver and be in a facility like that.
Okay. And as a group home, if a person moves into a group home, do they also lose their waiver because that's a different funding stream?
So I think that that's where it's a little tricky. There are specific group homes for the Innovations Waiver. I don't think that they can, like if they're living in a group home that doesn't take the Innovations Waiver, I think it's a decision point. That group home provider can do like a single case agreement or get in the network with the LME-MCO to then bill Innovations if the licensing lines up. Or they could be at a place where they're going to have to decide, do I stay in this group home or do I move to have some different type of care that's all under Innovations?
Okay, thank you. I think those were the last few clarifying questions, but you also talked about the tailored care management. Yes. And so the whole LME-MCO system has it hasn't been around that long, a couple decades maybe. There were many, there were less, there were more. Now there's few, and the services that were provided. Sometimes there was case management. There were different things available to families to kind of coordinate the services. And it's gone away for a while. So now this tailored care management has kind of come back, but more, as Jenna stated, it's more for a whole a whole center what's the term?
Whole person
Whole person
care.
care.
Yeah.
Yeah. That's why they're looking at that. If you've been around for a long time, you may have heard of case management before. But this is kind of doing a more holistic approach for our families and people with disabilities. So with that said, there are no more questions in the Q&A. I want to thank Jenna Flynn tonight. Again, you speak effortlessly and eloquently. You explain everything basically in plain language. You speak slowly so we could all keep up with what you're saying. So I just want to thank you again. I want to remind everybody that we'll be back again in October. I believe the session is on special needs trust and ABLE accounts. I apologize if that's wrong. I do organize this and I should know what it is. And I also want to throw out there, I know there's a lot of people from a lot of different organizations and family members who have children with different disabilities, because this is not Down syndrome specific. But I do want to remind everybody that October is Down Syndrome Awareness Month. And if you are affiliated with a local Down syndrome organization, I hope that you will support them in some way, especially since our largest events and fundraiser of the year is usually a buddy walk, and they'll be coming up in October. So whether you fundraise or not, or whether you just get out there and meet other people, especially, someone like myself, I have a 22-year-old son. There's parents of children who have much, younger children, and they don't have the opportunity to meet teens and adults with Down syndrome. So I encourage all of you to get out there and meet your younger counterparts if you have an older child, and whether that's Down syndrome or autism or any diagnosis, there's families behind you that really need to know that it's going to be okay. So that's my last plug. Again, Jenna, thank you so much. I will be following this up with an email, hopefully next week, that will include the link to the video, Jenna's slides. You need to complete your brief survey that you got in the email yesterday. And that will be in there next week too, in case you didn't get to that. So everyone, I wish you all a good night and a great rest of the last few days. The last day of summer, maybe. I'm not sure when autumn starts. So, okay. Everyone, good night. Thank you. Jenna, good night.
Thank you.